Good evening, everyone. I would like to welcome you to our October AABIP webinar. On behalf of the moderators, Dr. Siwei Lo, Majid Shafiq, and myself, Audra Schwak. We're also very appreciative of our new webinar coordinator, Dr. Chris Urosco, and would like to introduce him to everyone. So now, before formal introductions, we'll go through just a few housekeeping matters. First, please everyone note that this webinar will be recorded, and it, along with previous and future webinars, can be viewed on the AABIP website, and they can be found under the Education tab on the front page as shown here. Now, during the webinar, please note that you as the audience will be muted, so you can't verbally interact with the speaker or audience, but you can certainly ask questions and communicate with the group during the webinar. We certainly encourage that. All you need to do is type your questions or comments into the chat box or the Q&A function. That can be accessed by clicking on the chat or Q&A icons located at the bottom of the toolbar on your screen. Please make sure that your chat is set to direct to all panelists and attendees so that we, along with the entire audience, can see the question. We'll keep track of all the questions and comments as they come up and address them toward the end of the session in a formal Q&A period, but feel free to type in your questions at any time. We'd like to quickly reiterate that the AABIP does not endorse any specific technologies or products, and the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So now we would like to introduce our topic and speaker. We'd certainly like to thank Olympus for sponsoring tonight's webinar. We're really excited to hear about the topic of why keeping your traditional peripheral bronchoscopy skills is so important, with the technology advancements we've had in the last few years. Our speaker tonight is Dr. Alex Chen. He's an interventional pulmonologist at Washington University School of Medicine, where he's the director of interventional pulmonology and a professor of medicine and surgery. He served on the board of directors for our AABIP and has been very active in the American College of Chest Physicians. So we're very excited and appreciative to have him here tonight to speak with us on this topic and for the discussion that we'll have afterwards. So with that, I will hand it over to Dr. Chen to begin.
Thanks, Audra. Thanks to the AABIP and Olympus for putting this event on. I'm going to try to share my screen here. Let's see if I can do that. All right. Hopefully everyone can see that now. And I'm just going to start running through. The team asked if I would give a talk on traditional bronchoscopy skills in the era of robotics. And so we'll try to focus a little bit on that. Here is the disclaimer. I am not going to read it, if that's okay. And I'm going to go ahead and start here. So the talk is a peripheral bronchoscopy, why the fundamentals matter. And just the overall objectives over the next 45 minutes or so. I'm going to tell you a little bit about myself and our own practice. I'm going to convince you that there's not really a problem, but that I think we need a level set on how current technology performs. The reason I say this is because I think you can't go to any conference or meeting right now without hearing people talk about diagnostic yields of whatever they are, basically. And so I know some people are getting outstanding diagnostic yields. We really want to talk about where the literature suggests the yields actually are so that we can start off and say, look, this is ground zero. This is where we need to improve from. And then we're going to get into why traditional bronchoscopy skills matter. I'll talk a little bit about what I think traditional bronchoscopy skills are. And that translates into how you handle the scope, how you use your tools, and then really this concept of CT-anatomic correlation. How do you read a CT scan and apply that knowledge to bronchoscopy? I'll make an argument that even in this era of navigation, I think that that's a relevant thing to sort of talk about. So starting this talk off, who is it for? I think it might pique your interest if you do any type of bronchoscopy. So we talk about peripheral bronchoscopy as if it's an own entity, but it's really not. Bronchoscopy is essentially bronchoscopy. So any skills that you pick up, master, or hone in the periphery, they're going to serve you well in any aspect of bronchoscopy. So if you improve your skills in the periphery, your ability to handle endobronchial disease, do biopsies, those types of things will just get better as well. If you've ever gotten a non-diagnostic biopsy, so I kind of talk about this flippantly, but if you've had cases where you've just mastered the navigation essentially and gone exactly where the system tells you where to go, and you land exactly where you're supposed to, and you take your biopsies, and it's non-diagnostic. Why does that happen? Clearly, if you do enough of these procedures, it's going to happen to you. And so this talk is for you. If you're currently in training, this is something that I talk about quite a bit with program directors for pulmonary and critical care fellowships or interventional pulmonary fellowships, where they say, you know, reflexively, we're using technology like navigation or robotics now for peripheral lung lesions. And we're a little worried that bronchoscopy skills are not quite what they used to be or where they need to be. So clearly, if you're in training, that's an issue, or it can be an issue. If you're out in practice, the idea is, hey, look, you've been doing bronchoscopy for a long time. Take advantage of those skills and add to them using these new technologies. And the last one is if you love the History Channel, because I'll talk about old stuff that you probably don't even know about anymore. Feel free to tune out if your peripheral bronchoscopy yields over 90%. So again, I hear from people that their years are outstanding. They don't need this talk. They're doing something right. Either it's selecting patients in a very specific way. My guess is that you've tuned in, maybe you have an interest in this, and maybe you feel like there's some room for improvement. I'm also not going to recommend what the best system is. I always hear questions about this. What do you think is the best system? Really, it's whatever works well for you. The idea here is to talk about fundamental bronchoscopy that's going to help you with whatever system you plan on using. So why should you listen to me? I'm apparently quite old. I'm older than everyone else that's probably on this call. I don't feel old, but I trained in an era of pre-navigation, which was early 2000s up until 2010 is when that came out. Clearly, I precede robotics. This is an era where, look, if you wanted to go after a peripheral lung lesion with a bronchoscopy, you had to be able to read a CT scan and try to figure out how to get there. The other thing is that I promise I'll be fair. So this is an industry-sponsored talk, but they had really no control over the content of this. I'm not really going to talk about any specific system. We're really going to focus on essentially bronchoscopy skills and what I think helps sort of improve diagnostic yield, or at least consistency when you're going after lung nodules. So one of the disclaimers is that there's not a ton of data for the back half of what I'm going to present. It's mostly style. So you sort of take that or leave it as you will. All right, so again, the first few slides are going to be to level set on where we think the diagnostic yield of guided bronchoscopy is. And so if you look at more contemporary data that's been published within the past 10 years or even less than that, the best quality data on navigation and radial EBUS alone suggests yields of about 50%. And I'll show you data for that. We'll go over each of these technologies individually. If you add like ultra thin bronchoscopy, there is some data that maybe that improves diagnostic yield. And that's very specific data that I'll show you. What are the barriers to better yields? Well, over time, I think we've demonstrated that we can find peripheral lung lesions, and we can identify and confirm lesion localization with technology like radial EBUS. Eccentric lesions or lesions that are adjacent to the airway consistently show lower diagnostic yields. And in most of the studies that have reported this, those make up about half of the lung nodules that we see, and that can be an issue. We also now know about this thing of CT to body divergence. What does that mean? How do we mitigate and minimize that as a barrier? So talking about some of the individual technologies, radial EBUS, I think you all are commonly using this now in the era of robotics, because that is often how that is technology is reported. It is the original EBUS. You put the probe in contact with the peripheral lesion. It is not a navigational tool. It is a confirmatory one that says, yes, I found it, and now I can biopsy it. I always liken this to doing an ultrasound prior to a thoracentesis, saying, look, I can confirm there's fluid in front of me. This is where I should stick. And the other thing that it does, as we've learned over time, is it defines peripheral airway anatomy. What does that mean? Diagnostic yields are significantly different if the airway that you're in leads to the middle of the lesion and gives you this concentric radial EBUS view, whereas if the airway goes adjacent to the lesion and gives you this eccentric radial EBUS yield. Diagnostic yield with a concentric view is consistently 70 to 80% in the literature. Again, that's as good as a CT-guided biopsy, though the complication rate is only about 3% with bronchoscopy. However, when you've got an eccentric view, the diagnostic yield drops to about half of that's what I typically say. What about navigation? You guys are all familiar with this. It's based on procedure CT scans, which generate virtual airway reconstructions. Often there's a magnet or something that you track during the procedure that tells you where you are. The most recent data that's been published on this in a large series was published about a year ago. We were part of this study that was published in the Blue Journal that looked at 160 patients prospectively and showed that the diagnostic yield to be about 49% using that criteria. Again, this is where I'm getting this number of about 50%. What about ultra-thin bronchoscopy? This has been around for quite some time. Our colleagues in Japan have published quite a bit on this. It allows you to get a little bit further in the periphery. For those of you who are not as aware, ultra-thin refers to anything smaller than 4 millimeters. So in this instance, that's a 3 millimeter scope with a 1.7 millimeter outer diameter. A thin bronchoscope would be something in the 4 millimeter range. In this study, that was a randomized control study looking at ultra-thin versus thin. They showed a statistically significant improvement in diagnostic yield, all using radial EBUS, and in this instance, virtual bronchoscopic navigation, which we don't see very often in the United States. Moving on to robotics. So this is a study that we published in 2021, looking at a prospective multi-center study using robotic bronchoscopy. The idea was really to show feasibility and safety. And we showed that, again, it was about as safe as any bronchoscopy you might do. The ability to locate peripheral lesions was about 96%. I didn't go over that, but in the radial EBUS data that I presented a few slides ago, I also showed you that the ability to confirm lesion localization was about 96%. So that's very similar using the robotic system and conventional bronchoscopy. Diagnostic yield was an exploratory endpoint, and in a relatively small number of patients, it showed that the yield was about 74%. This is a very, very small number of patients, 54 patients, and this study was not designed to really explore diagnostic yield, which is why it was an exploratory endpoint. If you were at CHEST a few weeks ago, this data was presented. This is the largest prospective observational study in robotic bronchoscopy, 679 patients at 21 centers. They looked at safety as a primary endpoint, and they used diagnostic yield calculated by the strict criteria, so this strict definition that was recently published in the Blue Journal and CHEST, looking at how you calculate diagnostic yield. That number would be in the low 60% range, and I didn't give you the exact number because that number is going to change a little bit when the manuscript gets published, but it will be in the low 60% range. So this, I think, provides us with reasonable ground level and ground truth for where we start off with and why we have the opportunity to continue to improve diagnostic yield. If you look at the better data now, I think that a reasonable approach is to say guided bronchoscopy offers yields of about 50%, maybe 60%. Diagnostic yield for nodules lower than 20 millimeters is actually lower. That's consistently been shown. The robotic yields in larger studies are in that 60% range currently. There is no comparative data, so not very few of these technologies, if any, will say that one technology is better and can prove it with data. So what we typically have is examinations or investigations looking at singular technologies. When you go into smaller studies, case series, retrospective, single center studies, the diagnostic yields can be reported a little bit higher, but then again, there's a higher risk of bias in the investigations, and that's just the way that stuff goes. So this gives us kind of a baseline for where we're going to start off with. So there is work to be done, and how do we optimize our yields? What are we really looking for with peripheral bronchoscopy? The goal is to maximize efficiency and optimize diagnostic yield. So we would be incredibly happy if our yield was 100%. If it took us 8 hours to get that 100% yield, it would be a little challenging. So we're looking for something that maximizes our efficiency as well, works with our workflow and serves the patients well. One of the opportunities we have are to go back to basics and develop those skills that we started learning in fellowship, but perhaps didn't develop thoroughly once we got into practice. Utilize your pre-existing knowledge of bronchoscopy. This is such a big deal because if you're picking up a new procedure, if you're a novice just like anyone else is, regardless of how many years you've been practicing bronchoscopy. So if you've been out in practice for 30 years and you're picking up a brand new procedure that has never been done before, that you've never been done before, don't approach it like approach it like someone who's had 30 years of bronchoscopy experience, because that will make you better using new technology. We want to be very thoughtful about how we interface with the targeted lesion. So how far away are we from the targeted lesion when we biopsy it? Do we know exactly where it is based on the CT scan in relation to where the airway is that we're in? Look at those things, examine CT scans, and you might get some important clues that will help you during the procedure. What tools do we use? So we've got an embarrassment of riches, different tools. What do we use? Is there data to support using any of them? And then how do we confirm lesion localization? Is there a role for that that says, all right, well, I'm using a virtual-based platform to get out to the lesion? Is there value in having real-time lesion localization before taking biopsies? And I would argue that the answer to that is going to be yes. So let's talk a little bit about what traditional bronchoscopy skills are. I kind of separated this relatively arbitrarily into three categories. One is scope skills. How do you handle the bronchoscope? How do you handle the tools? Ultrasound skills. So when you're looking at an ultrasound image, do you know what an eccentric and a concentric view are? Do you take the time, if you get an eccentric view initially, to poke around and see if there is a concentric view somewhere to be had? Because I just showed you the data. If you can find a way to the middle of the lesion, you've doubled the likelihood that you're going to get a diagnosis. And then anatomy skills. So reading a CAT scan, knowing your anatomy, and understanding what CT correlation actually is. So for those of you who haven't seen this is a map. And it says on the top of it, Rand McNally. And so we used to have to learn how to read one of these in school. I doubt that's the case anymore. But it's really important to be able to look at that CT, translate that information as a map into your bronchoscopy as you're doing the procedure. All right, why is this important? We're being asked to do something that not a lot of our colleagues are being asked to do. So we're being asked to biopsy moving targets. And there's not a lot of other organs that do that necessarily to the degree that lung nodules will move. We published a study in 2015 which showed the movement of lung nodules between end exhalation during normal tidal volume breathing and a full breath hold. And you can see that there's 25 millimeters worth of movement in the lower lobes as patients breathe. So this is something that can lend itself to things like CT to body divergence and is one of the important reasons we have to understand what we're trying to do and all the different things that can happen while we're trying to hit one of these lung nodules. All right, so I'll move on to scope skills. All right, so very simple, straightforward stuff that is incredibly easy to forget about. So don't forget about basic bronchoscopy. Focus on the live endoscopic image, not the virtual one. Again, this seems so incredibly simple, but I have watched so many procedures where navigation is being used, where the bronchoscopist is so focused on staying on one side of the line or following the path that they're ignoring what is happening endoscopically. To be clear, again, none of you are novice bronchoscopists to the point where you don't know where the right mainstem bronchus is or where the bronchus intermedius is. So we should really be only looking at these navigational components once we're getting closer to the peripheral lesion, because we kind of know how to get to the right lower lobe posterior basal segment. This video here that I'm about to show you, focus on this on these two images at the bottom. The bronchoscopist is doing an amazing job keeping the line centered in the screen, but doing a horrible job managing their scope through the airway here. You can see where we need to go is very obviously into this airway, and whoops, we're sort of in the wrong one there because we're really not paying attention. So focusing on some of these other things like the live endoscopic view, again, take advantage of that training. You certainly had it before. This is really what we'd rather see is nice, smooth control. The airway is centered all the time. We're seeing the probe. I like to drive with the instrument barely outside the tip of the scope. I feel like it makes me more accountable for how I'm driving. Here you can see which airway we're going into very clearly. You can see us go up, and we can see here that we've got a couple choices of airways as well. We can go either into this one or this one and know exactly where we need to be at all times. So there is something to just being able to identify those airway branches. The only way you can do that is if you're driving in the middle of the airways. So make sure that you try to do that. The other thing is get close. So there's no reason to try to hit the three-point shot when you can do the slam dunk. This is two examples that were done not too long ago, actually. This is with a 4 millimeter scope. This is with an ultra-thin bronchoscope. In both instances, you're getting a radial EBUS image. It's just the scope position relative. So the lesion is identified right here. And you can see here, like if we're trying to hit this lesion from way back here, if we're off by just a little bit, we're going to miss the entirety of the lesion. Here in this panel, we're a lot closer to it. This same angle of approach, the same angle of error right here, we're just going to have a better chance of actually identifying the lung nodule. And again, this is not rocket science, guys, but the opportunity to not settle on being far away from the peripheral lesion. Now, you might ask what that is. From our standpoint, if you look at peripheral lung lesion needles, or needles, if you will, that you use in the periphery, these are typically 20 millimeters or 15 millimeters. So look, if you can get within 2 centimeters of the peripheral lesion, you can probably hit it. Anything beyond that, you're taking a chance. So it would be in your best interest probably to get a little bit closer to the peripheral lesion. What about tools that we use? This is old data, guys. This is from 2009. We promote this all the time, where the addition of transbronchial needle aspiration to conventional diagnostic procedures, which in this study was transbronchial biopsy or bronchial washings. If you added TBNA to those things, you significantly improve the diagnostic yield without increasing the complications. So if you're not using a needle right now, that is one thing that you can do that immediately has the potential to improve your diagnostic yield. So we certainly recommend doing that. Radial EBUS image interpretation and optimization. So again, when you're starting to do this, I think the idea is, hey, look, when you see the peripheral lesion, you're really excited and you're ready to fire away a needle. In this instance here, we've got a scope, and this is a pretty big lesion, but you're going to see that the instrument goes high, and you're getting a very eccentric view. You can see that probe centered up here, the lesion heavily biased towards one side of that. That's an eccentric view. Doesn't matter how big this lesion is, the diagnostic yield is going to be in that 40% range. If you contrast that with what we're seeing here, where the instrument is going in a slightly different trajectory, you can see that the probe at certain points is completely surrounded by lesion. Here, there's some artifact here, but the borders of the lesion go all the way around. And you can see in this instance, diagnostic yield is going to be 80%, whereas over here, it's 40%. So take the time when you get a radial ultrasound image to convince yourself, if you have an eccentric image, that there isn't another airway that goes right into the middle of the lesion, because again, at that time, you've just doubled the likelihood you'll get a diagnosis. And again, another tip that I think a lot of you have probably realized is that once you start sticking something and causing a little bit of bleeding in the periphery, that alters your radial EBUS image. And it will give you this sort of false idea that the lesion is actually there, when really what you're seeing is blood. So your best chance is to do the hard work up front, make sure you've got the best possible image, and then stick it, as opposed to rescanning with ultrasound after you've already stuck it a few times. All right, one of the big things that we talk about in our training program is identifying this idea of what a target zone is. So where actually is the peripheral lesion? I'll show you the video right here, which we'll show you as we move the probe out, we're starting to see the peripheral lesion with the radial EBUS image. We don't stop there. So keep going and pushing forward until the lesion goes away, essentially. And at some point it will. And when it does, that identifies the distal border of that peripheral lesion. And that should go away right about eventually there. All right. And so what I'm going to show you right there, this marks the distal end of the lesion. Now we're going to pull the probe back. Keep coming back, 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 back. We're seeing the lesion again because we're in the middle of it. We're starting to pull back some more. And then as you see, as we get close to the bronchoscope, or inside the bronchoscope, it goes away. That's the proximal portion of the lesion. So you know that your biopsy tool has got to be between these 2 points. If you're using a needle, in general, the tip is the only thing that picks up tissue. So the tip has got to be in this targeted zone. It can't be out here. And we do see that sometimes. So for this now, you have your targeted zone right here. And you're going to see the tip of the needle stays inside this targeted zone. This is not as easy as it looks, because very small movements take you out of that targeted zone. So just remember, if you want to get a diagnostic specimen, identify the proximal border and the distal border, and make sure that your biopsy tool is within those 2 borders. All right, CT-anatomic correlation. I'll spend a little bit of time on this because I do think that it's relevant. But why bother using if the navigation system does this for you? Well, navigation systems aren't perfect. Poor airway reconstructions can happen when you've got someone who's got burnt out emphysema. If you've done this enough, you've all seen the horrible airway reconstructions where essentially all you get are the right and the left mainstem bronchi and some stumps that show as the upper lobes, lower lobes, and middle lobes on the right side. They can be time consuming as well, and you really need to know where you are when you're doing this type of procedure. It's just got to make sense. I tell people all the time the system should agree with you, not the other way around. What I mean by that is you should have some idea of where you're going and where you're trying to get to. I have a 16-year-old right now who's been driving for a few months. You know, when he's going somewhere where he hasn't been before, he plugs it into his phone and he doesn't think twice and he just starts driving. I'm always telling him, hey, look, pull up the thing where it shows you all the directions and see if it makes sense to tell you where you want to go, essentially. Does this actually make sense? And that's the double check that you should be doing every single time when you're using a navigational system is make sure the system agrees with what you thought, not the other way around. I have had navigation systems tell me that a lung nodule is in the posterior segment of the right upper lobe, when really it was in the superior segment of the right lower lobe. Now that sounds crazy, but those two areas can be incredibly close to one another. So it has to pass the common sense test. And you as the bronchoscopist, with your years of experience doing this, should be that common sense test and the double check. So is there data for an approach like this? There is actually. So we published this data almost 10 years ago, looking at the ability to identify peripheral lung lesions very simply by looking at multiplanar reconstruction CT scans, not thin slice, just whatever you have, basically. Coronal, axial, and sagittal images, looking at these and saying, all right, I think that the lung nodule is right here, and we need to make the tool go right here. And when we do that, 96% of the time, the lung nodule is there when we confirm that lesion localization with radial EBUS. Again, I showed you our previous data from the benefit study showing a 96% rate of lesion localization. This was the same. The mean time to lesion localization was less than 7 minutes. In the the benefit trial, mean time to lesion localization was 13 minutes using the robot. So if you can do this, it's faster. Most of the lesions were smaller lesions, and of course, if you had larger lesions and an air bronchosine, you could get to them more quickly. How does CT-anatomic correlation help you? All you're really trying to do is get some type of idea in 3 dimensions of where the target actually sits. So you absolutely can spend time looking at the CT scan, scrolling through, identifying LB9, little a, little b, those types of things. But what I typically ask people to say is like, okay, when we look at the axial image here, is it more medial or lateral? When we look at the coronal section, is it more cranial or caudal? And if we look at the sagittal images, is it more anterior or posterior? That's really all I want you to do is to have some idea of where it is that you're trying to get to when you're using the bronchoscope. So I'm going to go through some cases here, and all of these cases were done in our lab using moderate sedation and no navigation, no robots. So I'm going to just show you selected CT images here. This is a peripheral lung lesion in the anterior segment of the left upper lobe. I'm not going to scroll through all the images, but you can tell that here you can see the fissures and show that this is in the left upper lobe anterior segment. You can see the airway that goes out to it. Here you can see an airway that goes out to it as well. I'm going to show you some additional selected images here. What I like to do is I like to see the CT scan, see the airway, work my way backwards and say, all right, yeah, this comes and joins the apical posterior segment right here that you can see. And so I feel like more likely that this is in fact in the anterior segment of the left upper lobe. I'll show you some selected coronal images, which aren't very helpful. And then I'll show you here on the sagittal view that you can actually see that, yes, this thing is in fact in the anterior segment of the left upper lobe and not in an anterior branch off of the apical segment, as you'll sometimes see. So what are we looking for with bronchoscopy? Again, so this is very medial, going back here, this is very medial within the left upper lobe. And what I can show you is the bronchoscopy as we go through. Again, we're trying to drive in the middle here to identify all the structures. We're going up. We see the lingula down here, and we're moving up into the left upper lobe proper. This is the anterior segment. It's a little hazy. It'll get better in a second. Now we're going to drive forward and see. And at this point here, we have a decision to make. So which of these airways goes more anterior? We're in the left upper lobe. We are in the anterior segment. We have a choice of going here or we have a choice of going here. Well, you think about the anatomy of the patient, the way the patient's laying, keep it simple. The ones on the right are going to lead more anteriorly. So that's the direction that we're going to go. Okay. And then once we're in this location, this is when you'll turn your attention to the radial EBUS probe. You'll put it forward. I showed you this video earlier. This is a nice concentric view of this left upper lobe lesion. And then again, showing you the TBNA that was done of it, remembering that targeted zone essentially, where we want to keep the tip of the needle within that targeted zone. So in this instance, we had an idea based on the CT scan 3D multiplanar reconstruction that the scope was going to have to look like it was coming out towards us within the anterior segment. When we did that, we found the lesion and we found it very quickly. In this instance, the diagnosis was adenocarcinoma. All right, next case. So this was one that was done sometime this month, one that I was reluctant to do in the first place because the lesion's so remarkably small. This is something that had increased in size. There was a concern for recurrence of some sort of cancer that I can't remember what it was, but it was here. This is sub-centimeter. And again, I don't have a lot of reasons to go after sub-centimeter lung nodules unless it's grown significantly and unless it immediately affects some type of therapy that's being offered or at least contemplated. So here we have the peripheral lesion. I'm going to go back now that I've circled it. And the coronal section, the lesion's here. Underneath here is an airway that goes sort of right underneath it. You can see that same airway right here. My cursor's on it on the sagittal view. It is pretty much right underneath that one. So I'm going to circle that again, and I'm going to show you scroll down images. So we think that this is in the anterior segment of the right lower lobe. Again, it's right up against the fissure, so that's probably where it has to be. Within this airway segment, I see one that goes more anteriorly and one that goes more laterally. The lateral branch is really what I want here. And again, I can see that it courses right underneath my target. Now, one of the things when we use radial EBUS is it doesn't give us direction. So we don't know if we get an eccentric view, we don't know if it's to the right, the left, the top, or the bottom. But the CT scan here is telling us what we might be able to see. We might anticipate seeing an eccentric view. And if we do, we might have an idea that this thing actually sits above the airway. And when we did bronchoscopy, that's exactly what we found. So this was very quick and easy to find. We went right to it. We had an eccentric view, and we thought, you know what? With this view, based on the CT scans, we think that the lesion is really cranial to this peripheral airway, essentially, and that's what we stuck. So understanding the relationship between lesion localization and the airway allows us to really think about what we might expect to see during the procedure. Again, we see that the lesion's right here, this airway goes below it, and the sagittal view shows something very, very similar, and it really gives us direction, allows us to aim, and the diagnostic yield here is adenocarcinoma. Could you stick this and run cone beam or do something else? Of course you could. But if you have an understanding of what's happening, you don't necessarily always need to interrupt your procedure, stop what you're doing to position the patient appropriately and do a spin. And certainly that's only if you have the luxury of having some of these additional tools too. All right, the next case is an incidentalloma, 43-year-old male with renal failure undergoing renal transplant. The patient's a non-smoker and has no significant family history. Here is what they found on random CT screening, as every transplant candidate gets, this lobulated lesion down in the right base. You can see it sits kind of on top of the hemidiaphragm here on the coronal as well as the sagittal. Where is this lesion? I'm not going to scroll through this, but this is entirely medial basal territory. So if you see something down here, could it be anterior? Could it be posterior? It could be, but classically, this is exactly where the medial basal segment supplies. So during the procedure, going in, again, doing our very best to sort of stay centered up in the airway, go down with a 4 or a 3 millimeter bronchoscope. I can't exactly remember. We're going to go down, try to stay centered up, keep good visualization, be nice and smooth. We're going down here. This is the bronchus intermedius. This is the right middle lobe here, superior segment, right lower lobe. Keep going. We're going to keep going past that superior segment. Now we're going to turn. Oh, darn it. I just started it over. Sorry. You're going to have to see that again. All right. Here we go. So here, that's the medial basal segment because it's the first one that comes up before segments 8, 9, and 10. And we're going to go into that. And really, based on that CT scan, it's a straight shot down. So we know that once you get in it, it is a straight shot down. We're not looking for any branches that come off. So we're going to just keep going straight. You can see there's a dominant airway right in the middle of that. And so we're going to keep going basically past some of these little branches. And once we do that, we'll put the radial probe out and hopefully identify the peripheral lesion right there. Yeah, so we've got the probe out here. We still have good visualization. So once you feel like you're far enough, you're going to use fluoroscopy not to identify the peripheral lesion, but to make sure the tool is going where you want it to go. And you can see very quickly here, we're able to identify that peripheral lesion. Now we've got our biopsy instrument. Again, from my standpoint, I think driving with the tip of the instrument out makes you be a little bit more thoughtful about how you drive. And so we're going to turn into the medial basal segment here, and we're going to find that exact same airway. I think in this instance, we probably switch scopes to something smaller just to demonstrate that. And now you can see that we're in the same spot. We'll have another image here, I believe, that makes sure that we're in that right airway, that correct airway, that one that's a little bit more lateral right here where that bubble's coming out of. And then from this standpoint, we're going to TBNA this or transbronchial biopsy it or pretty much whatever you want to use. So staying centered is going to give you the opportunity to observe the airway branches. It's going to allow you to make educated guesses and thoughtful choices. This thing was all the way at the hemidiaphragm, and you would say, well, this thing's way out there and may not be accessible, but you'd be surprised how far these scopes go nowadays. So just having an understanding of where you want to go and then just making it happen will, in many instances, in most instances, allow you to make a diagnosis. In this case, this is also a case of adenocarcinoma. Next case I call the navigational nightmare. We've all had cases like this. So this is a 1¼ centimeter lung nodule that was found incidentally. Again, from this standpoint here, it's right in the middle. So this is not an easy CT guided biopsy. If you ask your surgeon, this would require probably a lobectomy and not a wedge biopsy. So it's up to you to try to get a diagnosis. In instances like this, a navigational system was used. And you did it perfectly. I mean, so you lined everything up and the system says that you're in it. But then you grab TBNA and the rapid on-site team says, nope, you don't have anything. Blood and bronchial epithelial cells. That's all you've got. And so the question is how can something like this happen? So that was before we used radial ultrasound. Then we said, all right, well, we had nothing on rapid on-site evaluation. So you put the radial probe through, and what you see is this eccentric view. And you know that, you know what, the navigation system did its job perfectly. It brought us right to the lesion, but the airway that was there through no fault of navigation said that, you know, the lesion is next to me and not right in front of me. And so I was only ever going to get a diagnostic yield of about 40% in that instance. So knowing this information, we were able to redirect and find an airway that went right to the middle of it. And when that happened, we repeated TBNA and rapid on-site said, you know what, this is good. This is squamous cell carcinoma. So having this component of learning during the procedure is really what real-time confirmation is all about. You know, you can't blame a non-diagnostic biopsy on navigation by itself because, again, its job is to get you close. It's how you use that information. So taking another tool and saying, yes, you are on top of it, but you're next to it instead of being right in the middle of it. Having that information during your procedures and then doing something about it, there's very few bits of technology that allow us to learn more about our patients during the procedure. Most of the information is given to you before it. But incorporating this type of information and processing what you're seeing will allow you to potentially improve your diagnostic yield. So this is an example of CT to body divergence where, look, the CT and virtual image said it's over here, but in reality, it really wasn't exactly there. And so why does that happen? Well, there could be a significant lapse of time between the CT scan and when you're doing your bronchoscopy, respiratory phase, inhalation during exhalation, bad navigation. That's less likely the cause, I find, but it can happen. So again, if you don't have those good airway reconstructions that lead all the way out there, then you might not be able to have sort of the optimal pathway that you would like to see otherwise. Using some type of real-time localization and confirmatory tool gives you information about the anatomic relationship between the airway and the peripheral lesion that you're targeting and allows you to make adjustments on the fly. All right, what about the mid-lung lesions or the inner lung lesions here? This is a 60-year-old female who had a history of tonsillar squamous cell. PET scan that was done for surveillance showed this FDG avid upper lobe lesion. This patient actually had gotten a navigational procedure elsewhere, which was non-diagnostic, so they were referred for further evaluation. So I will take your attention to the axial image up here in the right corner. So this is the lesion here. And you can see that it is relatively proximal, if you will, for a peripheral lesion. It's more centrally located. The sagittal, I don't think helps very much other than it shows you that this is the lesion and it's between this airway here and these airways down here. And so in this instance, we went after this with a peripheral bronchoscopy approach. We used a 4 mm bronchoscope. You can see the probe sitting out here, and we had a really nice eccentric view. We tried to get a little closer to it with a smaller scope, and we still could not improve that diagnostic yield. And then we said, you know what? We know that our yield here is only going to be about 40%. We know that this patient's already had a non-diagnostic biopsy. What else can we do with this? And so this is an instance where you should sort of say, well, look, maybe the convex probe EBIScope can get out there, because sometimes you get surprised. We've all been surprised by these lower lobe nodules, for example, that you can get all the way down. In some instances with centrally located upper lobe lesions, you can do the exact same thing. So this is a video showing what that looks like. We don't often get fluoro images of convex EBUS, but we had it for the peripheral bronchoscopy. So we said, well, let's just leave it on. And you can see here we've identified the peripheral lesion. This is with the EBUS scope wedged in the left upper lobe bronchus, which means it's almost certainly wedged into the lingula. And you can see you've got real-time needle aspirations of this, which is always the best way. Look, if you can reach it with convex EBUS, it's always better than using any other technology because you've got real-time feedback of the needle going into the lesion. So follow-up points, don't forget about your convex EBUS. I can't tell you the number of referrals that I get for peripheral lung lesions that we just reach with convex EBUS, and it's just simpler, it's faster, and it typically gets results. In this case, this is squamous cell carcinoma. All right, so last example, and we'll make this the final tests, and we'll do this case together. This actually was just done a couple weeks ago. So this is another one of those examples where we had a really tiny lesion that there was concern for recurrence, I think colorectal CA, and they needed a diagnosis. And they said, can you hit this this is an 8 mm lung nodule that was in the right middle lobe. You can see the fissures here. So very clearly, this is right middle lobe. Coronal view sort of supports that as well. I will show you another slice of this axial image here. And I'm showing you this to illustrate this branch point right here. And so this looks to be the medial segment of the right middle lobe. And this right here, you can barely make it out as a lateral branch of the right middle lobe. So this branch right here, that comes off of the medial, so a lateral branch off of the medial, if you will, seems like it goes into the correct territory to find this guy. And then on the sagittal view, there is another image where there's an airway that goes down and there's an airway that goes up. In this instance, the airway that goes up and more cranial is the one that we thought we needed to get into. So applying this to bronchoscopy, and I'll just show you some still images here. So this is the right mainstem bronchus. Everyone recognizes that. This is the right upper lobe. This is the BI. Going a little bit further, this is a classic view of the bronchus intermedius where you have right middle lobe, lower lobe, and then superior segment of the right lower lobe here. And over here, you've got the right middle lobe and you've got the the lateral segment and the medial segment. So we said we wanted to be in a cranial branch of the medial that was more lateral, if that makes sense. So showing you this is where we want to go. Now we want to go here into the right middle lobe, and within the right middle lobe, we want to go into the medial segment. So now pictures of this blown up. So here we've said we are in the right middle lobe medial segment. Now remember, this image over here, the lateral branch is right over here. I'm not showing it to you because I've zoomed in, but that's where it is based on our hand position and based where the bronchoscope is. So we said we wanted to be in a cranial branch, which is this one right here. And then moving forward, this is a view of this. So within this, we have the option of going here or here. And remember, the lateral branch, the lateral segment of the right middle lobe is over here. And we wanted to go in a lateral branch of that medial. So we're going to want to go over here, the one that's closer to the lateral segment. And then next, once we're in here, we have a choice of going into this guy or this guy. And again, we wanted the most lateral branch within that right middle lobe medial segment, and that's going to be this one over here. So we had direction each time, and all we had to do when we were looking at the CT scan was make those two choices. We know that this thing's in the right middle lobe. We need to go up, and we need to go lateral within the right middle lobe medial segment. When we did that, we immediately found this peripheral lesion here, and this is an 8 mm lung nodule. So going in here with a ultra thin scope or a 3 mm bronchoscope allowed you to get close, and then doing TB&A of that, and the diagnosis was metastatic colorectal CA. Using this approach with CT-anatomic correlation, radial ultrasound and ultra-thin scope, and a needle, the entire procedure, start to finish, scope in to wake time, was 34 minutes. So from a resource utilization standpoint, it allows you to have options. Let's say you can't get OR time, for example, to use your navigation system of your robotic system. There are opportunities to sort of do things in different ways that will improve your overall bag, if you will, bag of tricks to improve diagnostic yields, and that don't limit you to one specific space. So to conclude, I think this is an incredible time to be in the peripheral bronchoscopy space. I think new technology is incredibly innovative. We're all very excited about this, but it needs to be proven. So I've been around long enough to know that new technology has come on like wildfire, that people have adopted it rapidly, but over time, and I mean a long time, it's taken data to show that that technology was not perhaps quite as useful or as productive or robust as we initially thought. And we needed to be creative about how else do we solve the problem? Do we focus on tools, for example? Do we go back to honing bronchoscopy skills? I think that's where we are right now. One of the other important points, and I've said this before, is you're a trained pulmonologist or thoracic surgeons or whoever you are that's on this call, or you're going through training to learn to become one. Do not throw your years of teaching and experience away to become a novice at new technology. Think about the expertise that you bring in to new technology so that you can apply it and be better off than someone who's learning to do it for the first time. I could probably teach my kids how to do some of this new stuff. I'm hopefully better than them at biopsying things because I've had years of being a bronchoscopist. So just don't forget that. Don't sell yourself short. One of the things that's really important as you're thinking about improving your conventional bronchoscopy skills is it just allows you to become a better bronchoscopist. If you're doing peripheral bronchoscopy routinely and you're being more thoughtful about where you are in the lungs and how you handle the scope, then you're going to be better at EBUS and other types of things. It improves your efficiency. It allows you to troubleshoot and think through issues. I'm concerned about us as a community being overly reliant on any one type of technology. I've seen this happen in our communities before where they're very accustomed to using one type of system or one type of tool. When that goes down, they have to stop. They have to stop treating people with lung nodules and refer to somebody else. I don't think that should ever really be the case. And again, when you bring in experience, it allows you to be better with those tools. I promise you, if you are a good bronchoscopist, you will be a better robotic bronchoscopist, or better with navigation, or better with radial ultrasound, or ultra-thin bronchoscopy. You are a bronchoscopist first, and the tools are developed to complement your skills and not replace them. So don't sell yourself short on what you bring to the table. Utilize those skills and continue to develop them, and you will be better off whenever the next piece of equipment comes that's going to be disruptive. So with that, I'm going to thank you for your time, and I'm going to be done with my slides.
Thank you, Dr. Chen, for this excellent talk. It is so refreshing to hear this from you, really going back to the basics and laying a strong foundation and making use of that for the ultimate benefit of the patient. Got a few questions for you. What would you recommend for, folks who, let's say, have just heard you speak about this and they're like, yes, I have learned about radial EBUS. I understood what you taught me today or retaught me today. And I want to go ahead and get started. I've got this case coming up that could totally be done via radial EVIS because I can march out that airway on the CAT scan when I study the CAT scan. For those folks, Dr. Chen, would you recommend preemptively also planning a robot software and or also consenting the patient for that possibility in case unexpectedly radial EVIS does not get them the yield or the preliminary yield on Rose?
Yeah, I think it's always a good idea, Majid, to sort of have backup plans when you're using new technology. I think that if you're used to using one approach, then you can add on new technology as a complement. And then as you become more accustomed to it, you can decide then what the best approach is going to be for you. That gives you maximum flexibility, without compromising patient care.
Thank you. Great. Makes sense. Now, I saw in one of your examples, once you found the great radial EVIS view, the next sort of video clip was the bronchoscope going down through the trachea and all the branches all the way back, this time with the biopsy tool, with the sampling tool. Is that your routine practice, or do you try to keep the bronchoscope in place close to the target lesion, just replace the radial probe with your sampling?
Yeah, no, it's a good point. The key is once you're there, don't move. So no, we don't normally take the scope out and go back in. I think this was just to show an example of that. But yeah, that's one of the sticking points for the fellows is the biggest crime down there is to find it and then lose it. So yes, we do our very best, keep everything in place, and don't try to replicate the scenario. Don't pull out if you don't have to. Those are things that are important.
Thanks for clarifying that, and also speaks to your earlier point about, of course, after that first sampling, the picture might not be quite as pretty anyway, so it might become harder to navigate down to that same lesion after you're encountering some bleeding, etc. On a similar note, do you ever use the Olympus the guide sheath as well for really peripheral lesions or difficult to reach lesions?
Yeah, I think this goes into understanding the relationship of where you are, where you can get, how far out you can get, and where the targeted lesion sits. So, if you are more than 20 millimeters away from the lesion, for example, and I'm using that somewhat arbitrarily, but something like that, then there is no guarantee that the biopsy tool that you place through the bronchoscope is going to go exactly to the same location as the lesion. So I think using a sheath under those circumstances makes sense. I'll tell you with the use of 4 millimeter scopes, I can get within 20 millimeters of most lesions. With the ultra thin scopes, I think you can get closer, although not always. So in my earlier days, when we were using larger scopes, we would use the guide sheath very often, in about a third of cases. But now that we have these smaller scopes, which we routinely use for peripheral bronchoscopy, I think my guide sheath use has dropped significantly.
Thank you. That's very insightful. Thank you. For eccentric lesions, do you ever consider using an Olympus used to make it as part of the Varen system, right? The triple needle brush or anything similar to that, so that you can sort of go in multiple directions and hopefully at least one of those could hit the target.
Yeah, it's not my own practice. I know people who do this, and I think that there's nothing wrong with it at all. I think that there is zero data to support the use of very, very specific tools. I know that they're out there, and some of them perform in unique ways, and I would love to see some data. But from our standpoint, we know that using any type of needle can be beneficial. So I always say like, hey, whatever flavor needle you want to use, go for it. But make sure that needle is part of what you're doing.
Thank you. And on a similar note, one of the attendees asked about sort of some folks are beginning to rely almost exclusively sometimes on the cryoprobe. So your thoughts on that? Would you condone ditching the needle altogether and just using the cryoprobe for a touch prep too, even if you wanted to use Rose? What would you say to that?
I think that this is an area, if we're trying to practice evidence-based medicine, it doesn't exist yet. So you know as well as I do that a large study looking at the role of cryobiopsy for various lung conditions, including peripheral lung lesions, was done, and we should be seeing data on that. Probably within the next year or so, I would imagine, because it just wrapped enrollment not too long ago. From my standpoint, look, I encourage people. I think the idea of doing cryobiopsy is great. If you want to add to what you're currently doing, that's perfectly fine. But you need to make sure that you're doing something that's evidence-based. Okay. And right now, that's the needle. So if you want to use cryobiopsy, I think that that's fine. If your practice involves doing touch preps, I think touch preps are tricky. It depends on what the cytology tech is of the day and how they process those things and the nature of the touch prep you're getting. So there is some variability in there that's not well controlled. There's variability with cytology preps as well. But right now we have data that says that TBNA improves diagnostic yield and is safe to do. So I want to make sure that everyone is at least doing that if they're practicing evidence-based medicine. After that, if you're getting a non-diagnostic Rose biopsy, for example, using TBNA, I think as long as you can do it and do it safely, and you have a practice in place that sort of mitigates the concerns of bleeding that we're sort of looking into, then I think it's fine to do. But I still, for my own practice, are going to advocate using the needle first.
Makes good sense. Thank you. Final two questions. Any experience, any thoughts about the thinner convex probe eboscope, the UC190? Just curious if you've used it yet and what's your thoughts?
Yeah, so that current scope, the tip of it is a little bit smaller, but the insertion tube is the same size. So, the ability to get further generations out, that's limited. And so I don't have a ton of experience with that. And I haven't seen data that says that improves accessibility to some of these harder to reach places. We would love a smaller and thinner bronchoscope that has convex scanning properties. Hopefully one day we'll see those. But for the time being, I think it's important to note that the insertion tube is the same size as the 180 series. So I think that there are other potential advantages, including a less severe viewing angle. But in terms of its relation to published changes in diagnostic yield, I haven't seen those.
Great. Thank you. Thank you. One of our attendees asked about your preference in terms of sort of anesthesia plans. Do you do these under conscious sedation or general?
So we do all our procedures under moderate sedation. And I think that's a unique practice. The more I get to talk to friends and colleagues in the community, I understand that a lot of folks are moving towards general anesthesia, and I don't have any issues with that. The challenge that I think our colleagues are facing in the communities are that getting anesthesia to support cases with the shortage that exists can be challenging. And so being able to do cases under moderate sedation as well, if you're comfortable with that, increases accessibility and some flexibility. Now, having said the words moderate sedation, the process that we use is a little bit different. It sort of incorporates airway support and probably deeper levels of sedation than the person who's sort of waking up when you ask them their name. So there is a process for that. And it's not just one of these things where people are just hypnotized for their procedure. I don't think that would go well in terms of trying to manage peripheral bronchoscopy. So I think you have to be thoughtful about it, but it's doable. I can tell you that much. Globally, this is the way a number of procedures are performed in places outside the United States. So it is doable.
Thank you. Of course, that requires another added layer of good bronchoscopic skills, right? And the patient's not, muscle relaxation hasn't been used, and this isn't true general anesthesia. Thank you very much once again, and I'm going to hand this over back to Amanda.
Yes, I echo Majid. Thank you very much for taking the time to speak to us tonight. It was an excellent presentation, excellent discussion. We know you're very busy, so we appreciate the time it took for you to put everything together and speak with us. We also want to say thank you to Olympus, our sponsor for the webinar. I mean, this topic is applicable to all of us that take care of patients needing peripheral bronchoscopy. And it's really timely, I think, like you said, as more advanced modalities are developed and rapidly entering the market. So it's important to kind of remember our other skills. And everyone in the audience, please remember the recording for this webinar will be available on the AABIP website soon and should also be available on the AABIP YouTube channel. So make sure you let others know they can check it out if they were unable to attend tonight, or you can certainly listen to it again. And thank you to everyone who took time to join our webinar tonight. We hope you can join our future webinars and other endeavors from the AABIP. I want to remind you that if you're not already a member, please consider joining so you can take advantage of all the things that the AABIP has to offer. And this includes our members only webinar series, which is composed of a variety of topics only available to our current members. So make sure your membership is up to date if it's not already. And then lastly, we would like to invite you to join us for our upcoming webinar. The next one will be on Monday, November 25th at the usual time of 7 p.m. Eastern. We'll have a panel discussion about declining reimbursement for IP procedures, how this affects us. And we'll also talk a little bit about AABIP advocacy. So you definitely won't want to miss that webinar. And thanks, everyone. See you next time.